The opportunity in our lab to do 3D mapping. So this is computerized mapping of the bone to see the footprint of the Lisfranc ligament. Okay, so what do we find? It's a broad attachment. Look at that. Just look at that area of attachment. Okay, this is the medial cuneiform and its base. Okay, so all those are attachment sites of the Lisfranc ligament. Big footprint, and that has to have some relevance, right? So you can see here again you are seeing end down. That's the cuneiform, and that's the base. So you see how that ligament is there, all the way from almost middle to the plantar aspect. One slip actually goes to the third metatarsal as well. It is almost like a double bundle. Have you ever heard of a double bundle Lisfranc injury? It exists. It's just not in the knee, but also in the foot. We should actually do double bundle reconstruction, I think. I'm just kidding there. But so that's what's happening. There's a single bundle and a double bundle in some of the specimens we found out. And we actually looked at these mapping areas. You see it's a very broad footprint, very, very broad footprint. And I will tell you this, pay attention to this, okay? Very, very critical, very, very critical. So what do you see here? What do you see here? There is swelling, okay? If you look at that, that's a swollen foot. And obviously the patient came in and wanted an X-ray, there has to be something wrong, right? Okay, what about that? Who can see an abnormality on that side, on that AP X-ray? On your right. Raise your hand. Raise your hand. You'll get a prize. The first prize, steps to walk will give you a little certificate, extra certificate. Come on, shout. You guys have seen this. I've talked about this particular thing. Do you see anything different? Go on. I don't know. Can I? Yeah, you seem to be keen and see something. If you see something, you raise your hand. Somebody raise their hand. See something, say something. Oh yeah, go ahead, go. Huh? Flex sign. I am happy that you're able to see this immediately. My radiologist at my institution missed it. That's what the report was. See that? I can see it. Trained eyes can easily pick out. I'm not blaming my radiologist, but that's the thing. That is a little speck there, a tiny speck. That's all you need. That is all you need. Sometimes there's a speck on the medial aspect of the first metatarsal cuneiform joint also. Okay? You should not miss that. That is the instability right there. Right there is an unstable foot. You have a chance to provide stability right there. For this person, you can expect a good functional outcome. If you miss this, see what happens, okay? Because if you have soft tissue swelling, if you see a hematoma, like a bruising underneath, you can't let them go, okay? So this particular patient was let go. So pay attention to the dates, okay? So in America, the month is before the day, okay? So you see October, okay? So just follow up, keep up with me. So what's happening now? Can you see anything? Patient came back to the clinic again. He was sent back. I will tell you there's something there else, okay? There's something else going on there. Now what? I mean, this time they didn't have a weight-bearing X-ray, but now this is another month later, 6 weeks later. At least now you can see. What do you see now? Tell me. Big gap, right? Now everybody can say, oh, there is a Lisfranc gap there. Now, why is that happening? The muscles are powerful, folks. They do not sleep. You sleep, I sleep, muscles don't sleep. If there is an injury, there is a constant contracture. There is pain and therefore constant contracture. So these muscles are going in that direction, okay? So that's why if there is no restraint here, they will go drifting like that. These muscles are coming from just below the knee, very powerful. And they're going all the way to the phalanxes, little phalanx. FHL, where does it go? Distal phalanx of the big toe. But it's got a big belly and affecting all these things. So same thing with extensor digitorum longus tendon, flexor digitorum longus tendon. All these powerful muscles are continuously, 24/7, providing the deforming force. Even if you put them in a splint or a cast, it doesn't work. They will continue to work. You sleep, I sleep, they will continue to work and cause it. Therefore, you have to counter that deforming forces. And I'm going to share with you my way of countering those deforming forces. Okay, so that's what. Do you see that, what's happening? Dr. McCloskey has shown instability at the first metatarsal cuneiform joint, but that was the other kind. That was that was a plantar gaping. This is a dorsal gaping. Okay, so there is capsular ligamentous disruption right there. There's so much there already. Can anybody find anything else on that side, on that X-ray, on AP X-ray, for another gold prize, okay? Gold, you get a gold cup if you find something. Come on, folks. 10, 9, 8. Cuboid. Who said that? Who said that? You said that? Yes. Shout it out. You're right. It is a cuboid fracture right there. So it is kind of a nutcracker. So the forces. Now, if you try to imagine where the forces have started and where the forces have ended, you will know the forces have started here. Okay. So there is a disruption of the metatarsocuneiform joint. Yes or no? Yes. Good. And then it went down to disrupt the Lisfranc ligament right there. Yes or no? Yes. And then it went down all the way, and it actually crushed the cuboid. Therefore, this patient kept coming back to the clinic. And now, see, oh, okay. So now the radiologist said, oh yeah, there is a fracture in the cuboid. I don't know whether they said cuboid or not. Yeah, I think they did that. Okay, it's too late. Look at that, I mean, I tell you what, I mean, Jeff, do you think, I mean, you know, right? I mean, how difficult these are to reduce? Like 3 months down the line, is it easy? No. It's very difficult. Sometimes when you're trying to reduce this, the cartilage comes off in your hand. So you have to fuse them. And you may be able to reduce the first 2, 3, but the fourth, fifth, you kind of destroy them and you lead them to arthritis. Why? You had a chance. When the patient came to you, you had a chance to give them a lifelong, reasonably good foot, almost normal foot. But now that chance is taken away. Young person, livelihood in front of them, family, so that's why I think in this day and age, look at the date. I think, this is 2016, but I tell you, even now I see these things. My heart breaks. But you see, you can see this is avoidable, totally avoidable. Okay, so now if you had seen this patient earlier, how should you do it? If you do not do a proper fixation, that also, my friends, have consequences. Okay, this one, I'll show you some examples. Okay, so again, if you do a proper fixation, you will expect a good functional outcome. Guaranteed. What do we have here? Okay, a simple thing, right? What does the surgeon do here? Tell me, what has he missed? Yeah, I know you're trying to show the first ray and the second ray, Jeff, right? What do you see? I mean, that's a critical thing. Everything but, right? He's done everything but the most important thing. And, the forces are still continuing. So anyway, okay, so that's 2016. And that's what is missing, okay? So the stability between the first and second ray is missing. And what can you expect from that? That's a strong ligament. Go and look at those cadaver studies. Look at ligament is very strong. Then you appreciate what stability it was providing. It has a reason to be there. Okay, so you can see, I mean, you should have probably left it alone. Would have been okay. And then he went back. This patient went back to the same surgeon, and well, they probably realized that the gap is wider. So what are you doing now? Are you attacking the problem where it needs to be attacked? No, away from it. So he's trying to indirectly get the first and second ray together. I don't know what was the thinking behind it, what was the reason behind it, but it fails. For instance, it fails. If you have to provide the fixation, where it means, where it does it best. So then they had a hardware removal, third surgery, okay, 3 surgeries. 15 months later, you are left with this. I think we can certainly do better than that in these days and age. 2017, folks, pay attention. Not to, and again, if you look at that particular screw, okay, so you learn to put the Lisfranc screw. But when you are putting the screw, see what's happening. What do you think is happening right there? Tell me. So the screw is going from the medial. I don't care where you put the screw, but you need try to see what's happening. Okay, the base of the second metatarsal has been pushed away by that screw. It's not lining up with the medial what do you call that? Medial border of the medial cuneiform. Okay, so putting that screw in that direction can be challenging and also have a problem. Okay, what can happen if you either don't fix it or fix poorly? The problems can go up the chain. Okay, and you can see it's not just remains in the Lisfranc joint. It goes up to the Chopard joint or ankle joint or higher up. Even in the knee, patients they say with deformity knee, they have pain in the knee or in the spine too. That's why Pradeep has chosen spine and foot and ankle, right? Problem is the foot and ankle. Okay, so you see this particular patient has another patient. Okay, has they done a good job? Is that a proper fixation? Would you like that fixation? Would you want to do this fixation to your, your friend, colleague, right, family? No. You see, again, I told you about that base of the first metatarsal and second metatarsal. What's happening? They are at the same level. Will that be a stable scenario? No. It's bad. So this particular patient came back with even ankle, I think. Yeah. So another scenario here. Poor fixation. I see this all the time. I don't know. I mean, we're not teaching them enough or what? I don't know. But if you look at that again, so why are we doing this? I don't know. So you see, look at that. The ankle is also all that affects because there's a deformity below the soft. Soft tissues will take the ankle soft tissue is not working very well. You see that? So it's a spectrum, folks. Okay. Sometimes you see this, and sometimes you see this. There is a problem there too. These are the subtle deformities. Okay. So, and I think the forces went that way. Okay. So. And again, whenever, like Jeff was talking about, he doesn't like those classifications, newer P, C, F, D classification. I don't even like the name, to be honest. Progressive, collapsing. If I tell you foot is collapsing, the patient is worried. Really, it may be easier to convince the patient to have surgery. Your foot is collapsing. But how do you know it's collapsing? Are you serially monitoring that? I don't like the term. I know it's there, but the classification even more difficult. I like the original previous classification. Anyway, I'm diverse. So good. Let me get back to it. So whenever there's a classification you don't like, you probably try to get a classification which you like or can work with. I'll tell you what I work with. Okay. So this is my algorithm as well. Is the anatomy intact or not? Okay. So if it doesn't look intact, then there is a problem. If it appears to be intact, then I need to know it's stable or unstable. Right? Because if it's stable, why the hell? Okay, go, take a boot or cast and go. If it's not stable, we need to provide the stability. That's very obvious, right? But that also is obvious. Now I know a few people have picked on this speck sign or the fracture here, and then I was talking about this. If you look at that very carefully, there is a bony piece there right at that joint, and the joint is not also congruous. Okay, so there is instability there. What about this? Now, this is where people miss a lot of these injuries. Okay, so if the patient does not have a weight-bearing X-ray, so this was non-weight-bearing X-ray. If we just put them weight-bearing, you can see that. Okay. Now, this gap, if you look at the gap carefully, it's going up like that. Okay, it's not going transverse. So this helps you plan your surgical fixation too. You have to pay a lot of attention. So there are subtle ones and there are very obvious ones. Okay, it's like a spectrum. Even in those subtle ones, there is a spectrum. These are all maybe classified as subtle. I don't know. People think these are all subtle. But again, it's shades of gray there too. So I'm going to share with me how I classify these things. Okay. My plan is my thinking behind this is I have to identify the unstable joint. That helps me plan fixation, and probably has prognostic implications there. Okay. So I look at the anatomy, stability, and location. These three things will allow me to know where to do, how to do them. So I say, when you have a ligament and bony thing, so it's an osteoligamentous. Now, if you don't see any specks, there are no specks. Not all ligaments will have specks, folks. Okay? There are some pure ligamentous, extremely pure. That means you need not even pulling. So it's like IACL, right in the middle. Okay, I will show you the examples. I have examples of those too. So now, look at that. Okay, this is the end on. I'm just going to use this image to show what I mean by those things. So if the injury has taken off a chunk of bone, you can see in the CT insert there, that is a osteoligamentous, bone and ligamentous injury. Okay. Now, sometimes what may happen is that you may have, okay, so you may have just that. Okay, so it's partial ligamentous. So the part of the ligament is still intact. Those kind of patients, we don't know whether the gap is there. The gap is not there, but the pain is there. Okay, so that could be like kind of a partial tiny speck. You could see a speck. There is a speck here, right there. You see, so but they may still be stable though. They may still be stable. That's why those kind of patients you need to follow up them weekly intervals or a couple of weeks intervals. So then you know. Now this is going entirely in the ligament. So these are the pure ligamentous ones. These are the ones which you can probably have a poorer functional outcome. If these are the ones who may need a fusion. Because bone heals better to bone if it has taken a chunk of bone. But these might need, so we don't know yet. Okay, so now these could be partially ligamentous too. Okay, so it can be complete ligamentous, partially ligamentous. So there are so many varieties. There are some with the flex, some without the flex. So this is osteoligamentous. So now we're looking at the direction of the forces. Okay, if you look at the direction of forces, you can classify them differently as well. So what kind of force has gone there? It's vertically oriented, right? You can see vertical orientation. So it starts here and ends there. So if you do not stabilize the cuneiform and navicular caps, there's nothing here. So don't go about putting screws across this joint. Whereas you should put screws across the middle cuneiform and medial cuneiform for sure, and then the navicular and the middle cuneiform for sure. You certainly don't need it, because if you study the path of the destruction, or if you see the signs of destruction, that's where you need to go and repair, no? I mean, why else? I mean, if the hurricane is going this way, why are you going? So imagine, right? So that's how you need to know. So now this is without the flex. Okay, in vertical orientation, you can see the gap, actually increasing gap in the middle and medial cuneiform. Okay, so that's the kind of scenario you have. This is the controversial group. Purely, should we fix it or should we fuse it? There are studies there. You can go and look at those studies. Okay. So now direction of disruption. So it's a longitudinal disruption, and there could be a transverse disruption too. The patient which we fixed 2 days ago was a transversely disrupted stuff. So this is a transverse subtype. Okay, so you can see this particular fragment and the opening. See the opening. This is my stress X-ray, my finger there, of my hand. So you see that this is the forces went this way, not up and down. This is this way. Okay, so this is transverse subtype. And this is a vertical subtype. So now you have two ways of classification based on the direction of disruptive forces, based on the other thing which I said. Okay, so you have a flex or no flex, or bony or ligamentous pure. So you get 4 different things. So you could have transverse types also purely ligamentous or with flex, similar to longitudinal types which had flex and without flex. So you could have that. So I think they have a relevance in the outcomes with what you're doing. So longitudinal types with and flex, without flex. So basically you end up with like this. So you have transversely oriented trauma, longitudinally oriented trauma, and some are purely ligamentous, and some are osteoligamentous. So probably this group and this group doesn't do very well. This group and this group does well with the fixation, I think. So we don't have it. Okay, so there might be another predisposition. This my group, we did what all we did. So we looked at the ligamentous injury and then looked at all the radiographs and figured out this ratio is relevant. But I don't think it's useful. It's just anatomical knowledge for us as to why some people. It's like why female have ACL tear, that kind of stuff. Anyway, should we treat them all equally? I don't know. Okay, so management. Let's go to the management. This was what I used to do. Right? Guilty? Yeah. And then we found out K-wires don't work all the time. So then we went to screws. Okay, so now my friend from where is he? Mike Otter now. So his group did a good study. So he said 1 or 2 passes of the screws. You might get a skilled surgeon like McCloskey. He can fire a wire, get it first time. So people like me, unskilled, might take 2 or 3 attempts to get that in the center. So might make more than 1 or 2 holes. Each time you put a screw, you're kind of or a drill or K-wire, you're kind of creating some damage to the cartilage. So does that lead to arthritis? We don't know that. So some people, including myself, moved away from intra-articular fixation to extra-articular fixation. Just like you have on the wrist, you have plating, dorsal plating and things like that. So we put extra-articular stabilization. And we thought, okay, at that time it was pretty new. Or some people actually doing fusion. So this is the whole gamut of, but I think we're not doing this, but we're certainly, some people are still doing this, but most people are either doing this and that, right? I mean, I think the current opinion is that's what we're doing. But there might be scenarios we may still need to do that. Sometimes we say open fracture or just need to put things together and then come back later. If you leave them dislocated, that's a problem. Come back 4 or 5 weeks, oh my God, it's a struggle to put them back. So we just need to temporarily stabilize it. Certainly K-wire is a good idea to do that. I'm going to tell you about this Lisfranc screw. Okay, this is very, very critical. If you want to, all my thoughts are in this thing. If you want to take a picture of this QR code, you will get this how to fix the Lisfranc ligament injury. Okay, so you will go straight to the website wherein all I'm blabbering now is there. I blabber on YouTube too. Okay, if you like that, you press the like button and subscribe. Just kidding. All these young generation, they know how to like and subscribe, to the channel. Okay. All right, anyway. So this is my way of fixing things, okay, folks? My way of fixing things. What happened? What happened? Okay. Oh, so these are my thumbs. Okay, now which is medial, which is lateral? Okay, so look at that. Just my thumb pressure opening up the medial side. That is the amount of instability we are dealing with, folks. Sometimes more than that too. And that's because that's a strong ligament. We cannot ignore that ligament. Okay, so again, it's a double bundle thing there. Okay, so that's what is happening. The insert, this insert is from this particular X-ray only. Okay, so you can see how this opening and causes that medial border. So it needs a strong buttress, and the buttress should go from there. Okay, so if you put a screw there, you are likely to push things away. See, so all right. So that's the fragment, and this is my traditional way. I was trained to do like that. But it's quite difficult. At least I don't have a great aim from a larger body to a smaller body. Is difficult. From a smaller body to a larger body, much easier. So, I think I still see some people still do that. Maybe they are skilled, but there are problems. Okay, so if you put the screw that way, what might happen? You're aiming into a smaller target, like I said. Okay. And the other thing is when the screws go in, even if you put a clamp, the clamp tines can open up with that pressure of the screw. You're screwing. Oh. It might open up. So there might be a gap created at that fracture. Okay, so that's another problem with that. So like I said, the screw actually may push the base of the second metatarsus. So like this happened here, right there. And therefore, I advocate putting the screw in the direction I did for a couple of days ago. Okay, so I put the screw from the base of the second metatarsal into the medial cuneiform, easier target, and then the longer threaded portion is in the because medial cuneiform is much wider. Right, base of the second metatarsal is smaller, so I get the threaded portion in a much wider place. Okay, so into a denser plantar medial. How do I know that? We did a study. I'll show you, and it can actually compress that fragment instead of distracting it. If you from other side, it might distract. From this side, you might actually compress. Now, sometimes we actually deal with non-union and things like that, and if that is the case, it's easy to remove the head. The head can. But if the tail is down there, you're losing some real estate when you come down to fuse it and take the hardware out to fuse it. It might be tricky to remove this, but easier to remove that. Okay, that's another tiny advantage. So again, we looked at the density. The denser portion is better achieved from the other side. Okay, so this is just a case example right now. Again, you don't have to dissect it. You will see that the capsular dissection is already done. You just go through the skin and subcutaneous tissue. You see the joint. If you need to expose a joint, you have to do a lot of sharp dissection with a knife. But that was already exposed because of the injury. Okay, so, and then you just put a screw there. And this is, again, published in that particular journal there. And this is a 6 months follow-up. At that time, when I started doing this, I did not know whether the plate would break or not, whether you need to advise the patients to remove the plates or not. That's a question I get asked all the time. This guy is a runner, running around with the plate and screw still there in time. So I'm going to tell you something else. Okay, the more unstable the injury, the more vigilant you should be in seeing what's happening. When you're doing something else, is it causing something else somewhere else? That actually happened in our case too. When we're trying to bring the bones together, then it was moving the other parts of the bone. So again, anything abnormal, folks, on this side, on this particular X-ray. If you look carefully, there's something happening here, right? And there's obviously soft tissue swelling. When there's a soft tissue swelling, some trauma which makes sense, you should not let them go. You can see everything right there, all there. So this is a Lisfranc injury, cannot go without fixation. Okay, some people talk about, should we get a CT scan? How does that help you? When you are thinking about investigation, think, how is it going to change your management? If it doesn't change your management, I doubt it you need it. I already decided it needs stability. I can take the patient into the operating room, do the fluoroscopy. I know where the thing has gone, where instability is there. I put hardware where it needs to be. So I don't agree with CT scan. Okay, so, but some people actually get it anyway. Some patients come with a CT scan. You can have a look. It doesn't make sense to me. Those are all tiny flecks here and there. Is it stable? Is it unstable? I don't know. Okay, so, but you see, actually, if when I'm doing EUA, I know where the instability is, right? So do you see the instability? There's more gap there too. CT scan may not show me all that, but EUA will tell me that I have to fix this too, right? So see what's happening. I'm putting the clamp, I should have put clamp here, but if you look at the clamp here, what's happening is, just see, squeeze the clamp. See what's happening? When I squeeze it, that is not lining up. So I should, so I should be vigilant, and I should let that clamp be placed where it should be go, all right? So I put the clamp here, you can see it's better aligned. See the difference? Same thing in the syndesmosis too. You could actually shift the fibula out of the anatomic relationship to the tibia if you're not paying attention where those tines are. Do you understand what I'm talking about? Who's that guy that did that? I think he did a great study in JBJS. I forget the name, but you know who I'm talking about, right? So it will come to me later. So yeah, so you need to mind the torque. And then this is not a very great fixation. I'm not very proud of it, but it actually held up because I put the metal where it belongs to. Not very proud of it. I don't know what happened. I didn't probably have the hardware or anything, but this is a follow-up. It did not fall apart because I put this particular screw. That's the most important screw for me, and if things are holding up, So that's the long-term follow-up for him, and he did well. Okay, and then you can see the staple broke. So I think I talked about the two corridors. So I'm just going to briefly, because this is important. Again, have a big incision. That's a nerve right there. So we can see the first metatarsal cuneiform joint. I use the second corridor. In a second, I will show you. This is the second corridor. You can always see that muscle, EHB, belly, which we saw that in the demonstration. And then right there will be the second thingy. And you can squeeze that and actually realign. Visually, we can see the base of the second metatarsal lining up beautifully, and you feel happy. And you can use whatever hardware you want, but do not forget that particular screw. If you don't put that screw, you're not laying down a good foundation. I think that's a very critical thing. These things will do well. They will heal well. You have restored the anatomy, restored the stability, and you don't have any complications. But this is an example from, in the Indian Foot and Ankle Society has a WhatsApp group. Now, congratulations to you folks. You started a Foot and Ankle Society, Sri Lankan Orthopedic Foot and Ankle Society. Amazing, and we are privileged to be there, to be involved and witness its birth. The Indian Foot and Ankle Society has a WhatsApp group. It's amazing how they discuss all the cases they're doing, what they're finding, and so on and so forth. I encourage you folks to form a WhatsApp group for Sri Lankan National Orthopedic Society, and then you can share these cases with yourself, and invite whoever you want to, and we'll be happy to, and Jeff and Lee probably will be happy to join your group, a WhatsApp group. It's easy these days, communication, digital communication, so easy to form a group, share your cases. Jeff may say he will strongly disagree with me. That's okay. We can argue on the WhatsApp, and that's how we help each other become better. So this particular case, you see, this was done for this particular patient. This was from the WhatsApp group. This. So, but the problem is, and this was, you see, this is a particular discussion. Well fixed, but using this plate involves a lot of dissection and stripping of tissue, as you can see here. It frequently leads to the issue like, well, that's probably true. And the other thing is, you see, I wondered how the hell he avoided an important structure there. Obviously, I'm not blaming anybody, but I'm trying to, he's daring to put what he did. And then he gets the feedback, right? So he becomes better. So, some surgeons felt that, that the vascularity would be a problem there. Okay, I think we're close to finishing off this. Again, there are polling questions. You can actually identify where things are. Oh, there's a triangle. Did you see there's a triangle underneath there? I was making a big fuss about getting a triangle. Please get me a triangle. Please, so I use a triangle to get the foot flat like that, you see. So, and again, use the fluoroscopy, make those incisions, and I think this is a video or something somewhere. But again, okay, this was why I put that case. And now you could put that Lisfranc screw from the base of the lateral base of the second metatarsal into cuneiform through the primary wound. But I find it easier to just make a tiny stab incision like I did for this particular patient, because we have to retract the whole skin and then put the things there. So, a separate incision for Lisfranc screw. So if you want to do the screw in the way I am advocating, it may be helpful to have that hole, separate hole, for that screw. That's the reason I put up that case. Otherwise, rest is same. I think, again, for completion's sake, I'm just showing the photographs. I think this was, okay, what was this one? I think this was, I think this was the same thing. Okay, so, right, so future thoughts, okay? So, what can you do better? How things, is putting a screw the right thing to do? Okay, so you should never stop thinking. Is it too rigid to allow healing? Okay, so some people are questioning that, right? I mean, so because we know ligamentous, like in a syndesmosis thing, you need a little bit of flexible fixation. Can there be a role of flexible fixation to make sure that, because sometimes you remove the screw, things may fall apart, okay? So what is going on in those? So that's what some people are thinking, and I've been thinking that too. So, so maybe a tightrope, like we have tightrope for our endo button, suture endo button. Can we have the suture endo button for the Lisfranc? So this was a long time ago. We were given a grant from Arthrex at that time. So we actually came up with a model, 3D model, to test out this hypothesis, the screw and then the flexible fixation will be equal. Okay, so we wanted to test this out. And okay, yeah, on the lab, great. The screw and the endo button suture fixation was equal to, and better than the native ligament. Okay, so from lab to the OR table. Okay, so we want to be the first, right? I want to be the first to put this. So a long time ago, I was actually the first one, I think, to put that endo button. Because I have a study to back up. Nobody will come behind me. Things like that. So, but this is my first patient. Okay, so you can see. Oh wow! I got a patient after I did a study. I'm putting a suture endo button and see what happens. Okay, the alpha's inside there. The thing is, the freer is inside the ligament joint. So I drilled a tunnel and everything. But on table it looked great. And 3 months later, so tightrope was a loose rope. I think what happens is the endo button, the bone absorbs under endo button. So even if you get the rigid fixation first time, it absorbs. So the fixation was a problem. Maybe not the ligamentous stability, but the fixation was a problem. So bone got reabsorbed. So it's no longer a tightrope. It is a loose rope, folks, loose rope. So I was disappointed. Nothing screws up the results like long-term follow-up, right? So that's what happened. So there is problem with suture endo button, creep, stress relaxation, the force concentration. So these are all the problems. So interference screw, if you want to do the ligamentous reconstruction, so interference screw in the base of the second metatarsal or medial column may be a better answer than the endo button type of fixation for you. So, okay, so another thing we think about, okay, you're putting the screw, you saw the footprint, right? We mapped out the footprint on the medial surface of base of metatarsal and the lateral surface of medial cuneiform, massive area of Lisfranc ligament. Now we're putting this 4.0, 5.0 screw, just like we did for the articular surface. Are we screwing up the ligament? That's another question, valid point, right? So are we replacing the ligament with a screw? So we wanted to know how big a hole a screw makes. So we actually looked at that and got a publication out of it. And we actually take a substantial percentage of the thing. Okay, so what next? Okay, so endo button can fail, screw can damage the ligament. What else can you do? Can you do an allograft reconstruction? Okay, that's how we want to try it. I mean, like ACL reconstruction. Can you do that for the Lisfranc ligament? So that's our new area of thinking. We actually did this was some time ago with my resident. I have a great group of biomechanical engineers here. So we tested out our allograft reconstruction. We used the interference screw on both sides and tested. Thank you so much. Got it. all right? So how can we do this? Okay, so here is a 62-year-old female patient, Oh, I lost my slides now. Okay, came back again. Good. And you can see the soft tissue swelling. I don't want to belabor the point again. There is a gap there. This is a Lisfranc ligament injury, okay, folks? And then, so what did we do? We stressed out to see which joints are, opening up and things like that. Very critical. So now we're talking about, can we repair or reconstruct? Okay, so what are we doing now? So again, based on that study, we went and decided to put a ligament. After we stabilized the first metatarsocuniform joint, we wanted to give her the ligament in place of a ligament. Okay, so this is a new ground, and that's the guide wire, and that's going. There is a video, I think, somewhere. So you see that that we are dragging that. Now this is a synthetic, biosynthetic graft. So you can put an allograft if you want to, semi-T allograft, anything you want. So that's going in that corridor where the Lisfranc ligament should be there. So after that is gone, so we fix it in the base of the second metatarsal, and when you pull and you put a clamp on it, and then you put. So that's the suture anchor going on one side, I think. Yes, see that suture anchor going. No, sorry. This is screw going in there, fixing the ligament, the artificial ligaments, if you will, in the metatarsal. And if you pull on that side, you can see it's pretty stable there. And then we went out and put a clamp before you do the other side, right? I mean, you have to squeeze the area. And we did that, and then we were happy. We were very happy. So that's going on the other side. And we gave this patient a new ligament. I don't know whether it works or not. I mean, I do have some follow-up for these patients, okay? So that's the on table. The gap is gone. The gap in the Lisfranc area is gone. And this is the follow-up, folks. This is recent as last year, November. So, and the patient actually had no pain. That was surprising, more patient. I don't know, but returned to previous level of function. So that's 3 months. As against, 3 surgeries, doing the wrong thing, missing. That's why I said when I started off talking about this, we have the potential to put this patient, give that patient function back, right? But we don't. So these are my take-home messages, folks. Okay, study the mechanism. Like I said, there is a path of a hurricane. There's a bullet. There's an entry of the damage and then an exit of the damage. Is it going transverse? Is it going vertical? What structures are getting disrupted? Very critical analysis. CT scan, unless it's weight-bearing, probably will not give all that information. Evaluation under anesthesia, under fluoroscopy, will give a lot more information than a CT, non-weight-bearing CT scan. And once you do that, you know where to put your money, where it makes the biggest bang. So if you know the deforming forces, you have to counter the deforming forces and maintain anatomic reduction. So again, folks, like I said, MUA can design. And again, look at that the differential between the base of the first metatarsal and the second metatarsal. You need to make sure that is taken care of. It's all about the Lisfranc screw. Don't screw it up. Okay, in some of the publications, I am really lucky to have a great group of researchers with me, and they do most of the work. I say, okay, I want to know this, and I say, yeah, we take the project, run with it, and again, all this is in the QR. If you want to know what I talked about, if you missed that, this is a QR code. It has got all the information in it. Thank you for your attention. That concludes my Lisfranc talk, but if you have any questions right now, I can take, or if I can go on to my next talk, which is on deltoid ligament, but you probably have a question. Yes, sir.
You mentioned about that patient that had Lisfranc ORF, not fusion, but had the screws, and then the question comes up, they're still painful. Do you take the screw out and see if that makes it better?
Yes.
And then fuse, or what percent of the time taking the screws out makes it better?
That's a good question. My short answer is I don't know. I don't know. The question, if you got that question, so if you're putting transarticular screws, I don't see them very often nowadays, though. You might, I don't know. But in my part of the world, I think most people are doing extraarticular fixation or neglecting it like that, or forgetting about it, or screwing up so bad, putting plates and things like that. So yeah, that's a good question. I don't know. I I would think that you just want to take the hardware out. Sometimes the hardware is prominent.
Yeah.
So the screw head is going.
There's I think a lot of times they get better taking the screws out.
You are absolutely right.
I
You
do
know,
that first and then.
and then see what happens. Yeah, yeah. I think that's a very reasonable approach to take. Just to take the hardware out, and then see what happens. They might be the hardware-related pain is a real thing. I see that, right? I mean, I don't know if it's weather related or something, because they say, oh, I can predict the weather changing. I don't know. I mean,
It's just a mechanical thing.
mechanical thing too.
Motion of the joint.
Yeah, yeah, yeah.
Yeah,
Jeff.
we would routinely take out metal at like 6 months after a Lisfranc ORIF, because if you haven't fused the joint, then there'll be some motion, and either the hardware will fail or the foot's a bit stiffer than it should be, so you return some of the movement by taking the hardware out. Yeah, that's what we can do.
Good. Any other questions while I load the second talk?
Bernard, question or comments on how to deal with, from a timing point of view, for emergency management of acute, like, dislocations of the midfoot? Do you have any
That is a
comment on
great
that?
question. That's absolutely a great question. So the question is, when do we intervene, right? So when do you stabilize? So there are situations wherein there's a lot going on, right? I mean, this could be a part of a polytrauma or open trauma, and this could be I mean, you guys see a lot severe trauma, I know. And there could be disruption in the complete disruption in the foot and ankle or the femur and everything else, or you could have a chest trauma. In those scenarios, even if there's swelling, I like to reduce it if I have the opportunity. If the patient is not dying, okay, you can take your time. If you're fixing the femur or tibia, I go and reduce those joints. And if they say that you don't have, or it's too much swollen, so I just put at least a K-wire just to kind of get that semblance. Because the situation is like, what happens 3-4 weeks later, you go back in, they have been dislocated, they will not be easy to reduce. So that's why I like to at least reduce them and put 1 or 2 K-wires. That's enough. And then you can go back and then at leisure you can bring them down. Yeah, I think, is there anything?
Yeah, that was probably the similar point and similar experience that I work at a level 1 trauma centre, and particularly the trauma centres over years have worked out that the best way, when they've got an acute dislocation, there'll be skin at risk from the pressure of the dislocated joints. They're really swollen. They might be sick with other trauma. So you just want to reduce the joints as best you can, a closed reduction if possible. Put a couple of K-wires in just to pin across it and get some stability. That'll let the soft tissues recover quicker. And one of the other keys is to bury the K-wires, because if you leave the K-wires sticking out and then surgery's delayed because they're sick or whatever else, if you come back 3 weeks later to do your ORIF and there's pus pouring out from a K-wire site, then you're stuffed. So if you bury and tuck the K-wires under the skin, then that's safer. It won't pus out while you're waiting for the swelling to come down. And then usually it's 2 or 3 weeks you need to wait for those ones for the swelling to come down and do your open fixation, screws and or little plates.
That's a smart strategy. Thank you so much. I'm going to, if that's okay, move on to my second talk. Second talk is on, sorry.
Is there a sequence of fixation?
Good question. Yes, I know somebody will ask that. So yes, I mean, sequence of questions. So you need to start somewhere, okay? So if you want to think the foot as a medial column, middle column, lateral column, you start somewhere. You could certainly stabilize the medial column and then, or temporarily, put a K-wire in the first metatarsal cuneiform joint, get that, depends. So much disruption can occur or very little disruption can occur. So if there's no disruption with the first metatarsal and the cuniform, you don't need to do anything there. If there's more disruption, vertical disruption, you think, like I showed you those examples, you just go to the second column, the injury between the medial and mental column. So it need to do what makes sense. There's no hard and fast rule. But you need to have some kind of foundation to build down the other. Make sense? Okay.
So when they talk about intercuneiform instability in Lisfranc injuries, you have to fix the cuneiforms.
Yes, I showed you examples. I showed you examples wherein the injury is vertical oriented, right? So that's where you absolutely need to. Then there are situations where it's a transverse disruption. You don't need to in those scenarios. That's why it's very critical to know where the pathway of destruction has been, because you need to fix all that damage along that pathway. Okay. All right, moving on to another, a little controversial, I think. People are waking up to this. I am one of them. I was guilty as well. I think I hope to convince folks, what we could do better as regards to ankle fractures. Again, these are my disclosures. Okay, so this is a common scenario, right? We see a distal fibular fracture, and we see a big gap. So what do we do for this? Standard care, currently standard, for I would do the same thing, but we put a lag screw first, right? Lag screw, and then we slap a plate on it. Now, if still the gap is there, what's the teaching? Open the medial side, clean out that whatever there is, and then even then the gap is not getting reduced. What do you do now? Use syndesmosis screws, right? That's what I used to do, right? Many people would go down that road. If you ask trauma surgeons, they would do that. Open the medial side. If you cannot get the talus into that corner, open the medial side because the deltoid ligament could be flipped. Flip it out, and then squeeze the tibia fibula with a couple of syndesmosis screw. That's your way to deal with that gap. That's right, and that's a standard way. I'm not criticizing, but think. Every time if there is a problem, you need to think. Okay, so this is the controversial thing right now. Should the deltoid ligament be repaired or not? Okay, so I used to be in that camp, never needs repair. I have converted at least to say never say never. Okay, there are some situations you might require, and I'm going to elaborate on that. Let's look at the basic, a little bit of basic. Deltoid ligament, does it provide stability to the ankle joint? If you look at the anatomy, massive, thick ligament. There is a superficial part. There is a deep part. 3, 4, where is this? All these bones are, it does provide stability. Does it rupture acutely? You bet. In that case, you can drive a truck through that gap. Yeah, it has to rupture, complete rupture. Does it fail to heal sometimes? Yes, it does not heal every time. Can we help it heal? That's where we have controversy right now. There are people who say, no, we don't need to do anything. There are people who are beginning to say, yeah, we can do something better. That's where I am current. Where is the evidence? I'm going to show you some early evidence to help you change, at least think about it. All right, so Hinterman got this great anatomic in the same journal, which and not just the ligaments, okay. What else is happening within the joint? We started looking inside the joint before we fix it. And if you are learning arthroscopy, Anthony asked, who does the arthroscopy here? If you haven't never started doing arthroscopy, ankle fractures is a great place to start. Sam Adams from, where is he? Sam Adams, Duke, right? He has a great talk, absolutely phenomenal talk. I love his talk. What is he talking about? There is a hemarthrosis in the ankle, right? Blood in the ankle joint when you break it. Is that blood damaging the cartilage? And he's trying to show that it is. So he has washed out the ankles day one, like on presentation, and says that the cartilage, it is more preserving to cartilage. We've been doing ankle arthroscopy, wash it out, and looking at the lesions. We find so many things. Now, we are used to looking at the x-rays. We see the bone, we fix the bone. But what about the ligaments? What about the cartilage problem? There are so many things we are not doing it. I've been fixing ankle fractures for many years. We're still talking about it. It's so interesting. We send man to the moon, but we can't figure out the best way to fix deltoid ligament. Okay. So again, this particular man, Hinterman, he also did this arthroscopy and he found deltoid ligament, 40%. Okay. So, and we know the literature shows that nearly a third of patients have poor results if they have deltoid ligament rupture. Okay. So, okay. Now these are case examples. Hope to keep you all awake. Right. So who will fix the deltoid ligament here? Oh, yeah. Oh, Anthony, thank you. You're in my camp, right there. What about Jeff? He is still undecided. Sir?
I would fix the bone first and then
fix the bone, smart. Yeah, I mean, that's what I would do, I mean, still. So you see, not a big gap medially, but you can't be fooled. Sometimes, actually it looks a small gap. You stress it out, you have a big gap there, okay? So this particular surgeon, he was my trainee anyway. He practices somewhere close by. And he did a good job, I would think. I mean, I'm happy with that. I could live with the OR with that kind of fluoroscopic images, right? Certainly nothing wrong with that. That's a staple still there, the follow-up X-ray. Looks good, yes? Now what's happening? Now what's happening? See, disappointment, right? Can we avoid that disappointment? That's my question. Could we have avoided that disappointment? Anthony gave a great talk about, even a millimeter. Karthik Hariharan, my friend, he repeated that study. Just a millimeter shift can doom your ankle. Whereas fixing, providing the stability, the ankle cries out for in the first place, you may avoid all that, right? So think about it. Right, another example, 2018. Look at the dates. Most of these extras are from my institution. I work with so many colleagues there. All right, so this is what they did. Happy about it? Because again, this is standard teaching. If you cannot reduce the gap, use syndesmosis screws. It will close the gap. Yeah, you can go home, sleep. Yes, I go home and sleep, yeah, with that X-ray. But follow up, see that. Look at that amount of instability there. You can actually, move the talus out in and out of the ankle joint there. Horrible, right? Could we have done something better? I think so. So we know deltoid ligament does not always heal, folks. Will syndesmosis fixation suffice? My plea to you folks, maybe not, okay? So avoid that disappointment. Oh, okay, so this is the philosophy. I shared that philosophy with Pradeep in my talk in Kolkata as well. After stabilizing the lateral column, okay, you will not bat an eyelid for fixing the fracture on the medial column, right? There's a medial malleolus fracture. Would you leave it? Would you leave it? No, right? There's medial instability because the instability is in the bone. But you're quite happy to leave the instability if it is in the ligament. Why? Why the discrimination? You are discriminating against ligament because both of them can provide instability. But when it's a fracture, no questions asked. I'm going to put a screw in there. Even if it is not displaced, I will put a screw in there, or would like to. So, but if it is a ligament, we're happy to script. This is a bimalleolar equivalent fracture, folks. So we need to do something to make sure that the talus does not drift away, to make sure that the medial gap is not increasing. We have to think about that. So people wonder, are you repairing it? And that's why I think the whole controversy against repairing it was, you can't put stitch in the deltoid ligament. You cannot get hold of it, right? That's the thing. That's the thinking. I was thinking like that too. But folks, it's not like the Achilles tendon, right? The Achilles tendon, you have rupture. You can get hold of tissue here, and that actually is a repair. It's more like indirect repair we are trying to do, like the ACL. In ACL, or syndesmosis, for example, syndesmosis. You have a disruption of the fibers. You're putting a screw. You're not putting suture here on the tibia and the fibula and then getting the ligament repaired, but you're calling it a syndesmosis repair by putting a screw. You can't put a screw across the deltoid ligament, but you can do something else and call it a repair. So that's the terminology argument about that. When I was trying to publish this, how can you call it repair and all that kind of stuff? So can we help it heal? Yes, I tell you, I plead you, folks, even if you do not repair the deltoid ligament, make sure during the follow-up that talus is sitting close to the medial malleolus. Because what happens is, we see them at 2 weeks. Then next time we see is 4 weeks. During that time, the swelling goes down and the foot goes out. So that's where we fall. If there is a deltoid ligament injury, if there is a damage there, you need to continuously make sure that the talus is not drifting off from the medial malleolus. That's what we can do that better by putting a suture anchor or whatever it is. But if you don't want to do anything, you don't want to open up medial side, you want to maintain that gap, either by cast, inverting gap, or whatever. Just vigilant. Call them back every week, or give them in a boot with a pump. So at least it remains snug. I don't know, but I have gone into the camp of repairing, so I can sleep better. This is a fabulous, fabulous study. This study was published in Foot and Ankle from in South Korea, not North Korea, South Korea. So look at this. This got a deltoid ligament injury, right? So they have 3 groups. In one group, they did just what we do, ORIF of the fibula. Okay, and then, I don't know, for some reason in that particular group, every patient had hardware removed. Now you can see what's happening. There is a wider medial gap. Okay, and then the second group, what they did was they had a deltoid ligament. They used the syndesmosis as like an indirect fixation of the deltoid ligament. And when they removed the hardware, they could see that medial clear strips is widening. This is the second group. First one was just plating. Second was plating with syndesmosis screw with the hope that the deltoid ligament will heal. Now they learned, they've woken up now. So then they say, okay, we are not doing everything. So then, and then what they did was, okay, we need to go on the medial side and add some kind of suture repair, some kind of stability. So not only they had a plate, but also syndesmosis screw, and on the medial side they repaired whatever. Okay, and then guess what? The medial clear space was normal. A great study, right? So they compared, all the 3 strategies. And not only that, this particular man, Bob Anderson, he works with a lot of NFL players. And this is a great study too. See, these people are 2 or 3 times the size of me, NFL, and they can return to jumping and everything at 16 weeks after an ankle injury. Unbelievable, right? But that's what he did, and he started doing repair of the, he does open repair. Have you heard him talk about this? Yeah. I mean, I heard him talk about this thing, and the
The important thing on that is he recognized he was not repairing the deep deltoid that we know is the most important one, but he was repairing the superficial deltoid with that little way it peels off, and that indirectly.
That's it. That is it. This is the point. This is a point we need to understand. We are not putting suture. We cannot get it. It's like a mop end, tiny mop end. You cannot do that. All we are trying to do is ensuring the talus remains snug in that gutter. That's all. The gutter space should be remain reduced throughout the healing process. Because the deltoid ligament doesn't have much of a give. You see, so even if it be a tiny ligament, tiny, you have to respect that. See, so okay, so so this is what the argument was. Okay, so people in the camp of repair, say there's potential of better function. It may help prevent arthritis. It don't burn any bridges. So that's why I'm in the camp of repair. Okay, so examples again. So this particular patient, you see, I do arthroscopy, right? I told you. So it was not getting reduced. See that? I'm trying to see if passively I can reduce or not. That was the reason. See the reason? A big I see so many osteochondral fragments when I scope these ankle fractures. You can see that was obstructing. This is the medial gutter. This is the talus. That's the medial malleolus. And that was lies right there transversely, lodging it. So then you take it out, and you can see all this is mop end. This is all deltoid ligament shredded, and then you take it out and reduce. You see that it was not reducible. Now we take that out, it's reducible. And this is, with that fragment, fluoroscopy without that. Nice comparison, right? So, all right. So went in ahead, and this is where you can see. This is what Dr. McCloskey was talking about, and Bob Anderson does the same thing. You open it up, and you just need to repair the soup. You're kind of tightening up the medial side, and you have plenty of tissue there to do that. Use what the hell you want, as long as it lasts 6 weeks. And this is where I'm doing a suture anchor just to get some, a good purchase in the talus, and I'm putting that. Again, in the long-term follow-up, no displacement in the medial gutter. Happy. Patient returned to whatever, again, 6 weeks follow-up, and this is a 12-week follow-up. After that, they don't want to come back because they have to pay. It's very difficult to come back with X-ray and all that. So acute repair does not burn any bridges. Okay, so and I'll give some example where this should have been fixed. Here is an example. Again, 2019. Remember, this is all United States of America, my own institution. All these examples. Okay, so this was done. It looks good, So then what happens? See, it drifts off. You can see this syndesmosis disruption, but nothing was done. So I think, again, looking back what Anthony told you, this is not going to last long, right? You're going to get arthritis. So you see, could we have done better? I say, yeah. This deltoid ligament should have done something, should have been done to maintain that gap. We didn't. So this is what I'm saying. You see, if you do not want to repair, make sure that you change the cast every week as the swelling goes down. Ensure that the ankle is inverted. So now we're trying to repair. We're trying to figure out where should you put those suture anchors. Where? I'm doing this arthroscopically, all those things, deltoid. So this is a useful study. My friend Emilio Wagner did that, and and he compared which is the best position. Because again, we wonder while we're looking at that where you should put like a Cora and all that. Are we, if you're using a synthetic material, is it affecting the arc of motion and things like that? So that study is very useful for that. Okay, so here's an example. What we're doing is look at that. So we got that fixed, and then we're stressing out. This is open. You can see that's the posterior tibial tendon, folks. Okay, so complete disruption. That's the talus, and that's the medial malleolus. That was open. We put suture anchor, got that done. That was time I was doing open. Nowadays I do this through a scope. Again, good. So again, this not too long ago we did this. So now I say, okay, do we need to open here? If you have the skills to do with a scope, we can do this through a scope. Okay, so we went ahead. This was not written up at that time, so we went to a lab in Colorado, and I think there are some videos here. Okay, so you see, we put through the scope, we put the suture anchors, and we wanted to know where the hell we put the suture anchors. Okay, and then I think it will show you. I'm just cutting that. It does provide a lot of stability. When I open this up, you can see, boom, it opens up completely. You see, so that's me cutting that. See how I can open up more just with restraint. So it is possible we do that. Okay, that's a team we worked with in Colorado. So again, so I'm now using just a scope. Okay, so you can see that particular. And then the question is, do we do before fixing or after fixing, right? Because arthroscopy is better to do before. When I know that it needs deltoid ligament fixation, so I lay my foundation, I do everything inside first, and then at least, so now I'm removing that fragment, which you saw that fragment in the scope, right? Can you see that fragment there in the medial gutter? There's no doubt that the deltoid ligament is intact there, okay? Deep and superficial, everything gone. And actually there's a speck there too. That could be something. So we removed that speck, and then, you can see it's gone, and you can see that that's the talus. This is the place where the deltoid ligament, and then another medial malleolus. So possibly, Lee, I'm probably doing a deep, somewhere deep with a scope. Probably you can do some kind of a thing to bring the deep one close together too, because I'm using suture anchor on either side. So that's a suture anchor. We can do everything arthroscopically. There's so many companies coming up with things. So that's the scope in there, and then that's a suture anchor going in there. So okay. All right. So. That remained. So those are the poke holes. Okay, these are the poke holes for that. We need an additional portal. It's a tiny portal. Instead of opening up, this is not the portal though. This is a trauma. That is a trauma. That's a anteromedial portal, and that is just a medial portal, just to put those suture anchors. Okay, so suture anchor there. Okay, and then I went ahead to do the fixation, which is a breeze, and then. Another example here, medial partial or complete rupture. So this is what we think, okay, is it a partial rupture? Is it a complete rupture? Do we need to fix it a little bit? We don't. So all you need to do is that. See that? You had a doubt there, no? Whether it's a complete rupture or partial rupture. Because sometimes the patients are in a splint. By the time you take an X-ray, they look good, but you don't know the whole story. Take them to the OR, stretch them out. You can see you can drive a truck through that. So again, you can do the suture anchor. There are a variety of ways we are trying to, trial. You can do that suture anchor. And these are stress view, post, and then you can add that suture button fixation or whatever button fixation you want, syndesmosis, variety of ways to fix that. And you can see the medial gutter is maintained, right? There is no deltoid instability. You are taking that risk away by just adding this. Where, so that you can see that's a medial clear space. 6 months follow-up, folks, the screw broke, okay? Now, if you want to look at this technique, again, it's the journal which I'm editor of. You can train your phones there. You can see, how I do this stuff. I'll leave that for a second. And Patrick is my current resident. These are my current couple residents there. They were supposed to come with the steps to walk. They actually they wanted to come, but they could not. Patrick. So okay, now I'm talking all this bullshit. Some people are thinking, what the hell? He doesn't have any literature support and things. I gave a couple of examples, but you can't hang your hat with a couple of studies. You'll say, a lot of, when I argue with this, the trauma surgeons, they are not convinced. Even if I show all this, they're not convinced. Oh no, you go away. My own trauma surgeon is not convinced. How can I convince them? I think the literature is still just starting to build up. I don't know. Have I convinced you, Jeff? Have I convinced you? I know you're saying like this. Still on the fence?
Yeah, no, I've been doing more deltoid repairs than I used to.
Yeah, so I think, I was like that. I'm also, I'm trying to see, I sleep better when I do that. So, this is we did a literature search on that, and I think, in my mind, the evidence is there enough for us to not neglect, at least not neglect, okay? We used to, I believe, neglect deltoid side. With the ligamentous thing, we were not doing enough. That much I am sure. So you see, if you repair it, you have a good medial clear space. If you just put syndesmosis, you don't. If you just repair the lateral ligament, you don't. So I think, to me, you need to leave the patient deltoid stable. If there is a deltoid instability, leave the OR with providing some stability, or in the post-operative period, make sure it doesn't drift off. Do whatever you want to do. Because, we agree with bony anatomy and all that kind of stuff, but, when it comes to syndesmosis, we agree we need to fix it. When it comes to deltoid, people are still on the fence. This is another, the Yellow Journal, our Yellow Journal. We were invited to provide, review update. So again, that journal also is there if you want to train your phone there on that QR code. So again, I just want to finish off with one case of Mal United, because you see again, the deltoid ligament, how unstable that can be. You can see exuberant callus formation. Patient had been walking on it or limping on it. You can see the lateral surface of the lateral half of the distal tibia is not very good. Again, we could argue whether you need to fuse it or fix it. Sometimes, you can use that distractor if you have the pin distractor, but you have to mobilize both sides. The medial side, you have to mobilize like hell. And then the lateral side also, syndesmosis, sometimes you have to clear. Sometimes you have to clear at the back too to really bring them down. And you need to have a very strong buttress. I contour the plate. I'm just showing those plates because I don't like this anatomic plate. These are anatomic plates. They beat their chest. We did CT scans about 2000, and then we got, no, I don't want that. I uncontour it. So I bend it other way. Then when I bend the other way, what happens is you can get that screws as a bicortical purchase. And you can actually reduce these things sometimes, and this is a 10-month post-op, and I haven't seen the patient back. Okay. We talk about the medial side, just finishing off on the lateral side, you see. So we talk about the fibular. I know people used to say the tip of the fibula. I started thinking, okay, you have ulna plus and ulna minus. The ankle is similar to that. So there might be a fibular minus. Guess what? There is. Got my residents to look at a bunch of weight-bearing x-rays. Not every fibula, the tip of the fibula, ends at the lateral process, which is what we teach now, right? So if you have a patient, you need to reduce the length, reduce the rotation. How do you know reduction of the length is there? Look at the tip of the fibula. It should last at that lateral process. Not every patient. A new discovery. Folks, you see, there is always something new you can talk about, you can think about. Low-hanging fruits are still there. It's just, I'm trying to encourage you folks to see, don't take it for granted, whatever is in literature. That's what Mr. Hariharan did too. He saw that, I don't know what was the motivation, but it's an old study, Hamilton study, right? I repeated. Great, okay. I think we are nearly end. So we coined the term fibula minus. All right, so thank you very much. Again, end of my talk. I'm really grateful for this opportunity. Thank you, Pradeep, for inviting me here, and thank you for steps to walk to. I really enjoyed this last couple of days, really, hospitality and everything is so good. But yeah, if there are any questions here on this particular talk, or the talk, if you have time, do you have time, a few more minutes? I think it's a very important topic for me. And I think ankle fractures, in our trainees, we say, okay, you can improve your skills with ankle fractures, right? I mean, sir. Hey, Mike.
So this way we can hear. So you were talking about deltoid, but since this may be the time that we can talk about the ankle a second. So for syndesmosis fixation, what's your preference? Screw
Or suture button.
suture, the
Yeah,
tight
that's a
ropes,
good
or
question.
two screws, or 4
one screw.
cortices. What
Yeah.
size screw? All of that. What do you do
Yeah.
most of the time?
Yeah, that's a good question. See, again, I don't have one fixed strategy for everybody, but again, I look at the disruption, what age, how the patient did, and all those things. So that particular patient, you see, I don't think I would have done with the endo button, the malunited thing. So it's a chronic, so I need a really rigid fixation. I did that. So length unstable. If there is something which is length unstable, so I need to bring the thing down and fix it, then I'm more relying on the metal fixation. See, so I think there is a role for flexible fixation. I really like it. But you need to know where the flexibility, where it provides stability and what kind of stability you're aiming for. So every case is different. Now we talk about, if I'm using a screw, is it 3 screws or 4 cortices, 3 cortices? Again, if there's an osteoporotic fracture, or if it's a diabetic patient, I involve all the 4. I want more rigidity, more stability there. Double the fixation, like Anthony said earlier on. So those where I do not want to. So I think in athlete, just disruption, very high disruption. I'm just trying to bring the things together. I want to leave the flexibility. That's where I use the suture endo button. I think there's a role there. Nowadays, I'm actually replacing that with a bio brace. There's a synthetic element there. I'm trying it out. Just like for the ankle ligament, we have a patch like that we can use. So. Again, I think we haven't solved that issue for everybody. I think we have some ways we can address those. This is very controversial. I mean, very interesting.
Yeah, it's not a clear answer.
Yeah, not a clear answer.
I think what I've done most lately is to put if it's a really unstable one, put 1 screw and then 1 tight rope. And that way I can take the screw out and still have the tight rope. Because I think if you take 2 screws out, or all of it out, even in a chronic one, sometimes they, it's too unstable and it hurts. And then to scope it is and see how stable it is on some of these that you're not sure is a good thing to remember to do.
That's a good point. You see, I mean, people ask me why do I scope. You can see all those things too. I mean, even if you can see, if you can drive your cannula up there, it's disrupted. But sometimes it's difficult to stress and then actually visualize that instability. So I think it's a good point. I mean, I encourage you, if you are starting out, if you want to try scoping, try ankle fracture because you can distract. And the other ones to start is ankle arthrodesis. I mean, there the cartilage is gone. There's no further risk of losing the cartilage. People wonder, okay, it doesn't look that there's no gap in the x-ray, but you will be surprised. You will see a nice gap there and put your scope. And sometimes you don't even need a scope though, because you know where the ankle joint is. I scrape half the time without looking at the scope. You know where it is, but you need to look at it to make sure that you completed it. But if you become too skilled, you can rely with just scraping it out, maybe use a fluoroscopy. And then keep washing it out. Yeah. So many ways to try this out. Any other question? Sorry.
Do you have a strong feeling about that, Jeff? For the syndesmosis, which way to fix it routinely?
Yeah, I'm a tightrope person. Yeah, I've been doing tightropes for quite a long time now. There's a lot of evidence that shows probably slightly better results with the flexible fixation. Unless they're super unstable, and certainly there's a cost involved with the implant. But if you're as I would be a routine remover of the screw at 3 months. The cost of a second operation is more outweighs the cost of the tightrope implant. Just one usually, unless it's very unstable or a very big, heavy patient. Then 2, yeah. Occasionally I'll put a screw in still, if needs be in certain situations. Yeah.
Related to that, Anthony has a question. We're going to pass the mic on to Anthony, or he can speak loud, I suppose, loud enough.
So the issue with that is not to do with fixation. It's to do with reduction. The problem with screws is that they are malreduction machines. And I've said this in my talk in November here, that the best institutions in the land, when they've CT scanned their ankle fractures, the commonest problem is malreduction of syndesmosis. And if you've screwed it in, you're more likely to do that because your screw position is vital. So the advantage of the tightrope is that because you don't really get any compression from it, and because it stretches out, then you're less likely to get a malreduction. But the idea about the tightrope is curious because the Arthrex hasn't quite worked out whether you're supposed to do 1 or 2. Right. Because the Optec shows 1 on the front cover, but inside they tell you to put 2 at 2 different angles. So if you do that, you don't have a flexible implant anymore. And you don't get axial control with tightropes. I do a lot of pro sports, and the move there is to actually apply what Vinod's just said about the deltoid. The AITFL almost invariably tears off the fibula, and so you can just repair it and do a direct repair. Whereas the problem with the syndesmosis is that you're locking the gate without closing it. Actually, to close it, you need to repair the AITFL. Screws don't make the interosseous ligament heal. They don't make the PITFL heal. They don't make posterior malleolus fractures heal. So you've actually done nothing for your syndesmosis. So when you look at studies where they've removed the syndesmosis screw, CT studies, post-screw removal, there's about 25 to 40% loss of syndesmosis control because nothing has healed. Occasionally, the AITFL will pull off the tibia, but that's still a relatively straightforward hit. The problem is that we talk about syndesmosis as this one uniform injury, and we talk about deltoids as this one uniform injury. It's impossible to repair the posterior deltoid. It's about a centimetre and it's stiff. It doesn't move. You can't take anything through it. The anterior deltoid you can get a hold of, and the key with that is the suspensory ligament. And this is why people always say, oh, tib post insufficiency is common after ankle fractures. And what our understanding now is that actually that anterior part of the deltoid is not just key to the stability of the ankle, so the superficial part of the deltoid. It's actually the suspensory ligament that attaches there that goes down to spring ligament that's key. And if you get instability there, then you're going to get mid-foot instability. And probably a lot of these people that we think have got tib post problems actually have a failure of healing of the suspensory ligament.
Very insightful, thank you.
All right, thank you so much. Appreciate it.
I thought we were all using the same
Which
one.
which one?
Calcaneal fractures. Yeah. Okay, so we'll just try and finish up, get through this talk, a bit on calcaneal fractures, a little bit about the direct subtalar or sinus tarsi approach, but some general principles just to discuss and be mindful of. Okay, so calcaneal fractures, so different types of fractures just to run through. So we've got extra-articular, intra-articular, look at Bowler's angles, helpful. We're think about who can be treated non-operatively and which ones would benefit from surgery. High-risk patients we worry about and will probably have non-operative treatment because the main concern's wound healing issues around that area. So smokers, diabetics, non-compliant patients would be more likely just to be treated non-operatively. For displaced intra-articular fractures, there's still controversy and there's been different studies talking about whether surgery helps at all. But I think, as orthopedic surgeons, we all know in our heart that a reduced bone injury has to do better than leaving it displaced and out of position. So it's a bit hard to understand how some of these studies show longer term supposedly no difference. But if you look down at the sort of details of the studies, there is a difference, which we'll talk about. And then there's an operation and then there's operations. So you can choose a good operation and do it well and to minimise risks, or if it's not done so well, then you're more likely to get problems. So problems can be infection, wound necrosis, sural nerve injury, perineal tendon subluxations, joint stiffness, and post-traumatic arthritis. Talked about that. From a Canadian study, surgery results are better in younger patients, non-compensable patients, females, not heavy manual labour, if the Bowler's degrees greater than 0. A Sanders fracture classification less than 3, so if it's not completely shattered. And they actually do better when it's an open fracture to fix it, and non-smokers. But the other thing that's sort of not talked about so much, although they're on a scoring system, which is a very blunt instrument to determine really what the function is, some of the scoring systems, maybe not telling you the subtle day-to-day problems that some people are having that might score the same as someone else who's functioning much better. And then the longer term outcomes. So if you've treated them non-operatively, they're actually 5 to 6 times more likely to end up needing a subtalar fusion. Okay, so that's important. And then along those lines, the other thing we know is that the results of doing a subtalar fusion later is much better if the bone's initially been reduced and in a proper position. So even if you can't prevent them eventually getting subtalar arthritis and needing the fusion, it means the surgery to fuse it is a lot easier and the results are much better than if you've left them with a completely malunited and malpositioned calcaneum and hindfoot. It's impossible to restore that back to any semblance of normality later on with reconstructive surgery. Soft tissue concerns, so the extended lateral approach, look, if it's done properly and in the right circumstances, good soft tissue handling, the wound risk should be actually minimal. We'll talk about that. But if you're not mindful of things like that perineal artery, vascular supply to that area and multiple wounds, you can end up with wound necrosis and horrible problems. So soft tissue timing, so you normally need to wait for the wrinkle sign for proceeding with an open extensile approach. The direct subtalar approach is less concerned with the wound in that area, so it means you can actually go in and fix the bones a bit sooner, and that actually makes it easier to fix the bones before they've all started gumming up after 2 or 3 weeks. Smokers and diabetics usually avoid surgery, but it depends. There's the diabetics with minimal complications, and then there's diabetics on insulin, so they're sort of different spectrum there. So I'll just run through surgical technique for direct approach, or in general for any calcaneal fracture. I'll skip a bit over the angiosomes. So the direct subtalar approach, it's actually an old technique that's been sort of revisited, and it's been a bit more popularised in the last 10 years or so now. And then there's been more and more new minimally invasive plates come on the market, which are quite low profile. But look, you can still fit in, and I've done before, just any small fragment or mini fragment plate along the lateral border and supplement with screw fixation. That's possible and fine. Okay. So need some K-wires, you need a good Chance pin with a T-handle chuck for joy sticking on the calcaneum, and then your implants. The difficulties with the direct approach is it's indirect reduction techniques of the fracture, okay? So, and you cannot see it all. So you sort of need to have a bit of experience with probably the open extensile approach and learning the reduction techniques and where the fragments are and being able to see them a bit better. And then once you know those and understand them, then you can apply it to the sinus tarsi approach. So it's just that direct lateral approach to the subtalar joint. So we saw that for the subtalar fusion, tip of fibula, the base of fourth metatarsal. You can extend it out longer up and down if you need to. You can get quite a big exposure if you need it. So you go in there, sinus tarsi, see the subtalar joint, posterior facet. The perineal tendons are just in the inferior part of your flap, and you might want to just dissect out, and you'll need to see those and protect the perineal tendons. So that's looking in at the posterior facet, front of the posterior facet there. So you can look directly down onto the subtalar joint. You can put a laminar spreader in there that sort of jacks out the joint, gives you a bit better exposure. So you can see the joint surfaces extremely well and lift up the impacted, displaced fragment and see the reduction very nicely. So people compare it to if you're doing the extensile lateral approach, you're coming right up under that flap, and it's like you're in your backyard and you're trying to look over the fence into your neighbour's backyard to see the joint surface. Whereas with the direct subtalar approach, it's like you're standing on the roof of your house and you're just looking straight down the garden next door. So it does make it a lot easier to see the joint surface for the reduction of that. So the other thing is the perineal tendons with the retinaculums over the perineal tendons, and with calcaneal fractures you usually get a lateral wall blowout fragment which is attached to that deep aspect of that perineal sheath. So when you're going to put your plate in along the lateral wall, that needs to go under the perineal tendons, but you'll need to release and elevate the tendons off that bone fragment, because if you don't, then you might actually put the plate under that bone fragment, under the lateral wall. So that's another thing to be mindful of. So the order of reduction is usually disimpacting the medial wall with a elevator. You put a shank pin into the tuberosity, elevate the joint surface, put the K-wire in to hold that. And then there's, if you're looking at the textbooks, I don't have it here, for reducing the posterior fragment with a joystick, the heel will normally tend to tip into varus. It will shorten, but despite it being in varus, the fragment tends to slide out laterally. So you need to reduce those 3 components with your shank pin. So I put my shank pin directly through from the lateral side of the calcaneum. Some people put it from the back of the heel. So I put it in from laterally. So my reduction maneuver is pulling that down, tipping it into valgus to get rid of the varus, and then you're actually pushing it into the bed, which medializes that. So there's those 3 components. Once you've got that and the joint surface reduced, then I fire in just a bunch of K-wires. Hold it all in place and check your X-ray, see if you've got a good reduction. Okay, so that's talking about disimpacting that medial wall where it fractures out the medial wall there. There's the shank pin, so down, valgus, medialize. Then you'll put a lag screw. Usually I put a lag screw under the joint surface, just as a single screw under the posterior facet to fix usually the 2 or 3 fragments there. And then put a plate down over the lateral wall. Sometimes the plate might be over your screw, that doesn't matter. And then you'll fix the screw holes you can reach through that front part. And then if it's a longer plate going out to the back, then you will often just do a smaller little mini incision at the back end of the plate to put 1 or 2 of the screws in there, okay, without having to, then you don't have to try and lift up right up under that whole flap. Then depending on the fracture configuration and your stability with the plate, it's often nice and good to supplement with some extra screws. So you can run screws going, I'll show you a few x-ray pictures later on. So that's a wound that heals nicely, standard post-op management. So you can put extra screws in to help bolster and raft up the different fragments. So if there's a tongue type fracture, you might have wanted to clamp down that tongue type at the back and put a screw down to help hold that. And then you can see often some longitudinal screws you can run up from the back of the calc all the way up to the anterior process, and you can put even a bigger diameter screw there, or 2 or 3 of those. That'll help if your plate is not as long as you'd like and there's bits that need extra fixation. And then also if there's a joint depression fragment in the center of the posterior facet that's been depressed, you've elevated it. It's sort of often a floating type fragment, so depending on your fixation of that with the screws through the plate, you can sort of supplement that with just a holding screw. You don't actually wanting to compress it at all. It's just a screw that goes, and it's like holding that fragment up from underneath, 1 or 2 screws to jam up just under the joint surface on that posterior facet. So yeah, as you may or may not expect, but studies have shown wound healing risks are lower with this approach, so lower rates of wound breakdown and infection. That's the advantage. And the quality of reductions shown no difference if you're used to doing both approaches. So we'll just run through a few cases here. So it's a tongue type fracture, so the joint depression you can see is attached to the posterior superior tuberosity. It's all gone down. Intra-articular fracture. This is older plates, the first sort of ones that came out. And yeah, that's got all that elevated. So the key, once you've done all those reduction manoeuvres, put your K-wires in, is with these you need to check that Harris view, the heel view, and you want to check the reduction of that medial wall. So you can see there's that nice smooth concave curvature of the medial wall of the calcaneum. You want that ideally perfectly reduced, okay? That means you've got the heel position correct. It's not left in varus or valgus. So that's often called like the Shenton's line of the heel. So I don't know if you learn the Shenton's line for the hip, that's like the Shenton's line of the calcaneum. What about this case? I've deviated back into Vinod's talk, ankle fractures. We've got a distal fibular fracture here, have we? What sort of fracture's going on there? Well, of course, this is a calcaneal fracture talk. Why am I got a distal fibular fracture there? Is that a Weber A or a Weber B? There, bit comminuted distal fibula. Okay, well you could probably leave that or put some little screws in it. But hang on, go back. Let's have a look. What's happening under the fibula? Okay, that's not normal. And looking at the lateral, the subtalar joint's not normal. Okay, there's bone overlapping bone there. So this is not it's not just a fibular fracture, so that's why that's an unusual configuration of a fibular fracture. You don't normally see those type of fractures, okay, on a distal fibula like that. It doesn't fit. Go back, look at the ankle joint. It's slightly subluxated. Better investigate further. CT scan. Okay, so she's got a fractured dislocation of the subtalar joint, and calcaneum's dislocated laterally and is impacted up under the fibula there. It's pushing the ankle joint out of position. Okay, so that needs reducing and fixing. This lady turned up 8 weeks after her injury because that initial x-ray was missed. Okay, so how do you approach that? How do you fix it? Do you go medial because it's sort of off? The constant fragment is that medial sustentaculum, but the whole body is sitting out under the fibula, so you have to get to that and push it back down somehow. Anyway, so this was the perfect one for a sinus tarsi approach because it's not actually comminuted in the most of the calcaneum. It doesn't need a plate on the body of the calcaneum, and if you did a big extensile lateral approach, you still wouldn't be able to get over the top of that dislocated calcaneum and then back down into the subtalar joint. So that's where just coming straight in that sinus tarsi where the injury zone is means you can just with difficulty lever and reduce the and get into the fracture site, pull out that callus and push it back down, and then just screws across into that medial fragment to fix it, and that looks good. So this one's a joint depression fracture, so that joint depression separate to the posterior tuberosity. They're a bit more difficult and more unstable, so you need to make sure you've got good fixation of that fragment with the plate, and then you can see I've put those extra strutting screws up from behind, 2 of those there. When you're putting your screws across the posterior facet, an ideal position is a screw going right across into that sustentaculum medially. Make sure they don't stick out the medial wall below that because of your FHL tendons in that groove and your neurovascular bundles there as well. Okay, just some more examples there, and then we'll wrap that up. Thank you.
Questions for him? 2 things I would mention. back over sometime easier and feel it. So don't be scared to make a little incision on the medial side if you know you didn't get it reduced. That's one of the simple things.
Again, the medial wall reduction, you showed a great example of how the concavity has to be reduced, and sometimes it's difficult to get that, especially in patients who have been out of following the fracture for 2-3 weeks, and you try to reduce this, because all these muscles will contract, against this fracture, and then all this fracture will be fixed in deformity. It's very difficult to mobilize those things. So at times, I've used a distractor, one in sustentricular tali and the other one in the tuberosity, and you can distract that medial wall and get it out. Actually, it's a technique tip published as well. So I mean, how far do you wait it out? I mean, do you ever use, what is your indication for extensor lateral approach? Have you given up completely, or are there any situations where you actually use that?
I don't do as many calc fractures in recent years, just because I don't do on-call. But yeah, usually be doing if I've been offered the case in time, then within 1 or 2 weeks, I'll do the direct subtalar approach, for sure. If it's past 10 to 14 days, it actually does get a bit harder doing it through the sinus tarsi approach to try and unpick all that just through the indirect techniques. So then that's where the extensile lateral is still a good option to have,
So there's controversy about the Sanders, like highly comminuted fractures. What do you do? Do you still fix it, or should you at least, bring those bag of bones into some kind of semblance and leave it, or go ahead and then subtalar fuse it?
Fusion,
do you have one?
All the really highly comminuted ones, I've done a few primary fusions, but you still need to reduce and fix the whole fracture and then do the fusion. Okay, so it's not just in situ fusing it in a mal-reduced position, because that's going to be not so good for them. So that's a debatable and difficult decision to make for some of them.
Because malunited fractures can cause a lot of problems. We saw one right in the clinic, malunited fracture. So determine, as Anthony was again telling, where is the pain coming from? You have to determine whether it's a subtalar joint, which is arthritic, which is causing the pain, or is it the lateral wall blowout, or is it the peroneal tendon impingement, which can happen too, because our peroneal tendons can dislocate and cause pain. Sometimes the FHL gets caught up in all this. So we need to know exactly what is the patient complaining about. And sometimes it is a dorsiflexion, the talus has sunk in, and then the talus is horizontal. That means there is no more dorsiflexion left in the ankle joint. And that in a plumber or somebody who has to squat and do the work, it's going to be tough. So in those scenarios, when you restore, you have to restore the talus inclination. Very critical. So that's where you need to distract the posterior facet. So if you are dealing with a highly comminuted scenario, you need to make sure that you restore the height of the calcaneus, so that the talus will heal in the proper inclination.
I guess some other just fixation methods is sort of if the patient, they can't afford it, or there's no plates available, sometimes just screw fixation alone is fine. So using multiple combinations of those different screw formats can give you good fixation and stability. I've done that a number of times where the soft tissues are poor and you just want to minimize the amount of metal in there. That can work well. Or sometimes the really highly comminuted, smashed everything, soft tissues bad, poor quality patient, but it's just a pancake of a heel bone. It's still often worth trying to get some semblance of the shape of the heel back, so that to avoid those longer term difficulties. So you can just do literally the old-fashioned closed reduction, squeezing the heel back together, percutaneously trying to lift up a bit of the joint surface, get the heel in alignment, and fire a few big KYs up across the subtalar joint just to try and hold it there. Bury the K-wires so they don't pus out, but then take them out after 2 or 3 months' time.
That's a good point. You
Yeah.
see, obviously, people. That is there. Okay. So what I was going to say, the swelling. Sometimes the swelling on the lateral wall is not the swelling from the soft tissues. It is the bony displacement which predicts as a soft tissue swelling. But these days the MIS is getting more and more popular. There are MIS techniques to reduce also. If there's a lot of real swelling, you can actually do distraction techniques using manipulation to kind of get it. Within 24 hours, much more easier. If you allow it to settle down and then contract, and then soft tissues, the muscles contract and all that, then distracting those fragments much more. So if you're able to get to the fracture within 24 hours, and if there is a swelling to the hematoma or something within 24 hours, I will reduce it. Use percutaneous methods. Certainly, sinus therapy is much more forgiving than the extensor large methods. I have not needed the extensor another great point Jeff mentioned. So just squeeze those fragments, but make sure the wires and everything goes across the subtalar line to hold the reduction. Sometimes we just end with the K-wires within the calculus fracture we fall apart. So we have to transfix the subtalar line. Because we're fighting against Achilles tendon again, very powerful forces. Very
So with the sinus tarsi approach,
Look at them and just usually I'll put some just with the scissors release the perineal sheath, and you've got to be careful. The brevis is easy, that's on top. The longus is on the other side. There's quite a dense sheath that binds it onto the bone. So you've actually got to sort of snip through that to release it to lift the perineal tendons off the lateral wall to be able to slide the plate under them.
Great, I'll just use axial screws. We need to have axial screw in the medial column and also lateral column. And then I'm going to do such a column, this ST fragment. It just provides really great fixation. Just great, I don't know. Biomechanically as strong as those axial distributions.
I think all of this reflects a shift in what we're trying to achieve with surgery.
We're not going to prevent the subtalar joint from being arthritic. But the subtalar joint is arthritic with a dorsiflex talus is a nightmare.
Subtalar fusion to do, because you've got to put a bone block in there, and there's no approach that's going to be forgiving whilst you're doing this. There's always going to be tension that you'll be putting on and placing the Achilles. So the aim is really to try and think about the height, the width, and the perineal tendons. If you look at the CT scans, you will see the perineal tendons, and you're not going to see displacement of them through any of these approaches, because it flips out from behind the fibula. And if you do see those little fibular flake avulsions, you've got to be very suspicious about the perineal tendons having dislocated. These things are low-hanging fruit, squeezing the heel together to prevent subfibular impingement. It's actually quite an easy thing to do. Getting a perfect articular surface that's going to avoid arthritis isn't worth the soft tissue trauma that you may cause to get it, because you're still not going to avoid subtalar arthritis. But you can make life easy for the patient so that they can wear shoes if they don't have that lateral blowout, if it's not embarrassed, if it's not short, if there's not subfibular impingement, and all these other issues. So I don't know about you, Jeff. I think that I don't do many counts now either, but I think the sinus tarsal approach has been a game changer.
Yeah, sure.
But having slightly different aims to what I think we were pushing for with the lateral extensile approach. I didn't think that there was a single way to fix a tongue-type fracture until David Kay said to me, hey, why don't we try tightropes on this? Oh my gosh, that's been an absolute amazing discovery. The more Dickens pulls it, the more it pulls that fragment down. It's an absolute genius maneuver. That's the only other thing that's changed for me in that fractures. Not if you read the literature, the pull-outs.
Are you just looking at an
Pure
isolated?
tongue.
Oh, okay, parenting.
Which is
a different type of cancer.
Which is a nightmare to fix.
Yeah.
That's the emergency
Are any of
force,
those that's-
So if you do see a tongue-type fracture displaced, that's an emergency, right?
Yeah.
You understand? Because otherwise the skin will is at risk. And once you see the reckless and all that.
That breaks down quickly.
Right. So every interesting thing needs, or even though we like or not, we have to end. Right? This is a type of situation where we just say it's end of 2024 Colombo Step to Walk Botanical course. On behalf of Sri Lanka Orthopedic Association and newly formed Sri Lankan Orthopedic Botanical Society, I would like to thank all of you of this international faculty who came all the way down to Colombo to enlighten all our trainees, including myself and my colleagues, and expose much and depth about the botanical care in our country. So I look forward that our trainees would take it in for much more forward than we had as a trainees at that time. So as a gratitude, I would like to call upon all our international faculty members onto this stage. And I would like to call upon our senior orthopedic surgeon, Dr. Uday Silva, to hand over the token of appreciation for our speakers. Which one is better? I think better you go there. Yeah. Arpeting. Yes, first I would like to invite Professor Panch Bhavi to accept our token of appreciation. Just check the name first. Then I would like to invite Dr. Lee McCloskey to accept the token of appreciation. And Jeff Times, please accept our token of appreciation. And Dr. Anthony Pereira, please accept our token of appreciation.
And while you're coming up, it gives me a chance to thank you all again for hosting us. And Pradeep's been fantastic, and all the leadership has been. And we really thank you. I've really enjoyed our time. It was really, really good for us.
At least I must thank our financial sponsors, MediSurg International, for giving their fullest cooperation to conduct this event very successfully. I'd say that without them, I would not have done it that extent. And I think we must appreciate their support, MediSurg International. Thank you so much. Okay, thank you for everyone.